had asked you to give me now a date for the cat. I think the last drug we were looking at is apomorphine. We drew the structure. I did mention, and I'm mentioning it again. It has nothing to do with morphine. It's just similarity in the name. And we did mention that this drug is mainly important during the off period of PD when these patients are not sensitive to L-DOPA. So during those off periods, you can't give them apomorphine. We had just started saying it has a few challenges. Of course, it has a few challenges. One, because of its structure, whereby it is a catechol. If you look at the structure, it is a catechol. Catechols are usually very unstable, especially on exposure to oxygen. So it is unstable because of its structure. It also is rapidly metabolized, and it has also issues in formulation. Because of that instability, then you have issues in formulation because you cannot give it orally because of the fast metabolism, and mainly you can give it as an injectable. And even when you give it as an injectable, because of those challenges, it will have a short duration of action, and therefore you would need to give us more often than not, to give it more often than not as a continuous infusion. When you look at these people, we are talking about PD, these are people who are shaking. They have no stability in their movement. So once you again tell them to inject themselves, it can become a challenge. And that is the only disadvantage, the major disadvantage. I mean, those are the major disadvantages of apomorphine. And I think we had started on the disadvantages. So let us look at them, we finish, and then we move on to the other track. So we had done that slide to show the structural resemblance. We had done that. I think this is where we were, and we did mention that, of course, you can have issues with patient compliance in case you have people with needle phobia, and of course also it will cause local pain due to irritation and inflammation followed by formation of subcutaneous nodules. Those are just some of the issues that can bring non-compliance. And I think we were on challenges with apomorphine therapy. And the first one, as I've just said, we have inherent instability, which poses a complication in clinical practice. It has a lot of instability. This can occur because you can have oxidation of morphine as one of the pharmaceutical challenges when it is formulated as an aqueous solution. So you can have oxidation. It can undergo spontaneous apomorphine spontaneously undergoes oxidative decomposition in aqueous solution. Also, the catechol group of the apomorphine molecule is highly susceptible to oxidation, leading to emission of the quinone. So we are saying not only can it undergo oxidative decomposition, also the catechol can also undergo oxidation. And of course, once it forms the quinones, the quinones are also highly toxic because they have deficiency of electrons, very electrophilic groups, and therefore that can result in quite some toxicity. The decomposition of apomorphine is dependent on the concentration and is obvious, as well as the pH and temperature of the solution. All we are saying it is sensitive, its degradation or decomposition is pH and temperature sensitive. The chemical half-life of apomorphine is very short because of that. At physiological conditions, the additions, and I think we had said this, you can add antioxidants, you can add chelating agents or alteration of the formulation. pH are some of the approaches to prevent the auto-oxidation of the molecule. So that is one, the instability. So instability is one. The next one is now the metabolism. That was instability, where it's undergoing oxidation or degradation in aqueous media on exposure to oxygen. The other one is the deactivation of morphine. So this is the second disadvantage, deactivation of morphine upon metabolism of apomorphine after administration. And all we are saying is that it has also it undergoes rapid metabolic process. Let me reduce the volume of my phone. Metabolism. It can also undergo inversion, whereby the R form, which is a pharmacologically active form, can be converted into the S form, which has no activity. Just 1 minute. So we are therefore saying there can be inversion of the stereochemistry, giving us the S form, which has lower or no activity. Also, additionally, apomorphine is metabolized by numerous enzymatic pathways, predominantly in the liver, but also in the brain and tissue. So it also has a rapid metabolism. And once you have a drug again with rapid metabolism, again results in short duration of activity, and of course another challenge. Some of the metabolic pathways include sulfation or sulfur-oxidation, glucuronidation, and catechol-O methyltransferase, or catechol-O, or the oxidative O methylation, where because when you look at it, because of the catechol hydroxyl group, then you can undergo methylation of that hydroxyl group. Then large pharmacokinetic variability is another problem that you find that in different people, there is variation in their pharmacokinetic profiles. And because of that, again, it becomes a problem to regulate the dose, to come to standardize the dose, because different people have different pharmacokinetics. And you know, the pharmacokinetics are the ones that are responsible for the removal of the drug from the body. So large pharmacokinetic variability is reported between PD patients after subcutaneous administration of apomorphine. This inter-subject variability may be caused by the interaction of the drug and the various metabolites with plasma and tissue, which complicates the clinical dosing system. So it is difficult in the liver. And when you talk about fast-pass metabolism, we are talking about metabolism even before this drug gets to the site of action, and therefore again another challenge. So of course that is still under metabolism. So metabolism is a challenge, irregular or variation in the pharmacokinetics. We have said that is also a challenge. We have of course also said the fact that it also is unstable. That also gives another challenge. Parenteral administration of apomorphine, and this is now we have to go parenteral because we have seen the other oral route is not possible. And you know, parenteral route has a lot of disadvantages that you know even in pharmacology. The metabolic constraints account for a poor oral bioavailability in PD patients due to a high apomorphine metabolism. It has a very short plasma half-life after subcutaneous administration. So we are giving it subcutaneous, but again, it still has a challenge because of what we have called, say, the rate of metabolism is very high. It necessitates a high frequency of injections to maintain concentration of apomorphine in the blood and subsequently in the brain. A continuous subcutaneous infusion may be used, especially a pump. So this person has a small pump and they hide it with their clothes, and that pump will give sustained supply. So it will maintain the supply of the apomorphine throughout, because we are saying if you do not do so, it has a very short duration of action and might not be of very much help. A continuous subcutaneous infusion will be used if apomorphine subcutaneous injections exceed 7 to 9. Because you see, we are giving 7 to 9 injections, this can be very uncomfortable for the patient. So parenteral administration causes inconvenience to patients with PD and often leads to patient non-compliance, because we've already said there is variation in their pharmacokinetics. So you might have to give one many times. The frequency of administration might be very high, whereby we have said you might have to go for the pump. And what if the patient cannot afford? Again, remember, these people have tremors. How do you self-inject? You already have tremors. So self-injection might prove difficult for patients in late stage PD during off periods due to impairment of motor functions. So we are therefore saying, yes, apomorphine is a good drug for the off period, but it can also pose challenges to the patient, especially that we know the condition, we know the symptoms of this disease, we know that this patient is supposed to inject themselves. How are they going to do it? They might have to seek help. And of course, you know, most of us are not very good at seeking help, especially when it comes to illnesses. Apomorphine metabolism, so we've already mentioned, it can undergo oxidative end demethylation, it can undergo sulfur oxidation or sulfation, glucuronidation, methylation, catechol-O methyl transfer, let's not call it transferase, is the enzyme catechol methyl transfer, non-enzymatic oxidation, as we have said, because of the catechol groups and because of its own instability. The complexities of apomorphine uptake, distribution and clearance. Uptake is the same absorption, distribution and clearance probably contribute to its variability of clinical actions. We did mention that there is that variation, there is that intersubject variation. There's that variation between one person and another, and therefore, as we had said earlier, you cannot easily standardize the dose of apomorphine. So when we look at it, we're looking at some of the very common oxidative metabolisms or oxidative pathways. Of course, this is our drug here, and one of the routes is undergoing methylation. You can see this is a catechol. This is our catechol, and the catechol there. This is our catechol here. The whole of this is what we call our catechol, where you have the two hydroxyl groups attached the two hydroxyl groups attached adjacent to each other on a phenyl ring, and we are saying you can have the catechol methyl transferase giving us methylating that hydroxyl group. That is one route. And when that happens, of course, you have termination of pharmacological activity. You can also get, so you can get either the apocodeine. So you can see that's apocodeine. We're counting from here, 1, 2, 3. So remember codeine, just calling it the same names. Codeine is that form which has a methoxy group at position number 3. Or you can get the iso apocodeine, whereby now the methoxy group is at position 1, 2, 3, 4. That's the only difference. You can either get the apocodeine or isoapocodeine. That is the catechol methyl transferase. You can get conjugation, glucuronide transferase, and of course you get the glucuronides and sulfated compounds because of the fact that you have the hydroxyl groups. Hydroxyl groups again can readily undergo a glucuronide conjugation or sulfur oxidation, and that of course will give us the glucuronides and sulfated conjugates. You can also get, we had already mentioned, there can be inversion or racemization, whereby you have the R isomer at that position becoming or changing the R isomer. You can see this here has a beta orientation for the R conformer, and then for the beta, for the S conformer, it has an alpha orientation. And again, that conformation or change or configuration or change brings about this enantiomer, which give you this enantiomer, and that enantiomer is not active. The other one, of course, is what you have said, oxidation. These are catechols, and because of catechols can undergo can undergo even spontaneous oxidation, as we have already said, so that they are turned into the quinone. So those are some of the metabolic processes, rapid metabolic processes, making this drug unstable in air, unstable in aqueous media, having very rapid fast-pass metabolism, and therefore are difficult to administer orally, and even difficult to administer parenterally, and you have to resort, of course, to having what we have talked about, having a pump which will continuously deliver the drug. Unlike other dopamine agonist drugs, which are taken as tablets or patches, apomorphine is given by subcutaneous route only via intermittent injection or continuous infusion. It must always be prescribed by brand to avoid confusion and to ensure the patient always receives the same product. Remember, we have said there is some problems of the pharmacokinetics, and at times the pharmacokinetics are also influenced by the brand, because although we said every drug, every formulation has the apomorphine, but remember there are the additives, there's the excipients, we do have the surfactants, we do have the binders, and different manufacturers can use different binders, and because of that the different the different brands might have different disintegration rates, dissolution rates, and so on. And that's why we are saying go for one brand. Do not change it, because you might change it and you might have issues of delivery. And once you have that, again, the drug will have problems. Brands are not interchangeable. Continuous infusion is when medication is delivered by a small pump, non-stop into the body. Formulations approved for administration include some of these: subcutaneous injection, a multiple dose pen injector, and mini pump or syringe driver. So those are some of the apomorphine injections or formulations that are recommended. And do remember, we are saying this drug is mainly used when you have patients who are experiencing the off periods, even on use of L-DOPA. That is another of the agonists. Then we have also another agonist we call rotigotine. Rotigotine is also another agonist. And it, of course, it is a non-egoline, or these are non-egoline. For egoline, we had bromocriptine. So these are non-egoline, and it can be used as patches. For PD, it is a non-egoline dopamine agonist. It is formulated as a once daily transdermal patch. Of course, that is of advantage, but I believe some of these ones are quite expensive. So once daily transdermal patch, which provides a slow and constant supply of the drug over the course of 24 hours. So that is quite good. I'm hoping that it is indeed affordable. So of course, again, when you look at the economic status of quite a number of these people with PD, because of the fact that they are not able to work well, they have issues of stability, they have issues of movement. So some of them might not be not be financially able. So again, when the drug becomes very expensive, remember this is a chronic illness, that can also be a negative. It is an amino tetraline derivative, an amino tetraline, and I think this is a molecule we call the amino tetraline. So that is the amino tetraline. It is an amino tetraline derivative. It's again it undergoes metabolism, hepatic cytochrome mediated or monooxidase. Monooxidase. These are the mixed function oxidases. These are the enzymes, or the cytochrome P450 enzymes are the enzymes that are responsible for its metabolism. Rotigotine is extensively and rapidly metabolized by conjugation and N-dealkylation. As you have said, you can see up to this position, that group there is why we are calling it the aminotetraline derivative. And then, of course, for it to be the drug, I believe that is a structure which we have there, I hope. I think, or is that the metabolite? Let's see the structure. Yes, it doesn't have the hydroxyl. It has the hydroxyl group there. It has, yes, it has that the thiophene group there. It has the ethyl group there, and has the hydroxyl group. So I think that's the correct structure. Yeah. So that is the drug we are talking about. We are talking about conjugation and metabolic by conjugation. You have that hydroxyl group there. That can undergo rapid oxidative glucuronic conjugation. And then you have this N. This is an ethyl group there. Oxidative N deethylation, removal of that group. This group here also, although it has a thiophene ring, you still can see there is this alkyl group. So it can also undergo oxidative N-dealkylation of that group. And those most probably are the main routes of metabolism. Again, we can't tell of those routes of metabolism from looking at the structure. So when we look at it, here is our drug, and we are saying N-dealkylation. Again, that N-dealkylation is catalyzed by the mixed function oxidases or the cytochrome P450 enzymes. There are many of them. And as you can see, all we have lost there is that group. So it's oxidative N-dealkylation to give us the N-dispropyl rotigotine, N-dispropyl rotigotine, and what we have lost is 1, 2, 3. It's a propyl group. And of course, that again can undergo glucuronic conjugation, and that is because we have the OH group, which was already there. And then also it can undergo sulfation, whereby again it's a conjugation, whereby you bring in your sulfate molecule at that particular position. Then you also have the rotigotine. Rotigotine can also lose the whole of this group, as we have said, through oxidative again and dealkylation, catalyzed again by the mixed function oxidases. So you can see now this, we can call it, it is the N, is propyl, this one to ethyl thiophene. and this ethyl thiophene, because that's a group that you've removed, and now you have the propyl group intact. So you can have that, and that again can undergo sulfate conjugation. It can also undergo glucuronic conjugation because it already has a hydroxyl group. Then, of course, also we have said that the whole drug as it is, without having undergone any other metabolism, can still undergo glucuronic conjugation and sulfate conjugation. So when we look at the metabolic pathways, we can't be able to come up with them looking at, or we can't derive them from the fact that we understand the structure and we understand the metabolic pathways that the various groups can undergo. So it isn't complicated metabolism, oxidative end dealkylation, sulfur, and glucuronic conjugation, and I think basically that is all. It is only what do you start with, and those are the main roots, as we have mentioned, of metabolism. So that is an agonist. So we have mentioned quite a number of agonists. We started with those which were ergot derivatives, the non-ergot derivatives, and then of course we have come to the apomorphine, and of course the last one, which we have called the rotigotine. And you can see there is really no real structural resemblance, but these drugs have been found to have some activity. Even if you look at this, as we said, even for the other one, you can see that is the ring, and then you can see that phenylamine, the phenyl ethylamine structure, as found in dopamine, is also found in this drug. We also found it was also there in apomorphine. And that structural resemblance, as we have said several, is necessary to allow that drug to be able to interact with the receptor, which dopamine does interact with. So structural resemblance is usually necessary for these drugs to bind onto the same receptor. But fortunately, when they bind, they even bring the trigger excitation of the dopamine receptors. Then metabolic protective agents. So we are done now with agonists, and I think the last category is where we use metabolic protective agents. Of course, metabolic protective agents are drugs that will block the metabolism of dopamine. And we've already looked at one class where we say the decarboxylase enzyme. That aromatic decarboxylase, which we give as carbidopa. It's a very important drug because it will block the metabolism of dopamine, L-dopa, in the periphery. And once it stops it in the periphery, it will be able to move into the CNS. And then in the CNS, because carbidopa does not cross the BBB, in the CNS, it will be acted on by the decarboxylase to give us the dopamine very near the area, the dopamine, where very near its receptors. So we have that one we had already mentioned, and of course we have discussed carbidopa. So we have already given a short summary on that. Then we have the monoamine oxidase, and we want specifically the monoamine oxidase B, because we have monoamine oxidase A and B. Monoamine oxidase A is usually found in the periphery, whereas B is found in the brain. We want them to block the monoamine oxidase B in the brain and leave the monoamine oxidase A intact in the periphery, because at times, even in food, you are taking in a lot of drugs or a lot of compounds that can bring pressure effects. So if you block the monoamine oxidase A, you can get what we call hypertensive crisis. So you want to be very selective, go for the monoamine oxidase B of the brain, and you leave the other one intact, so that you you do not precipitate the hypertensive crisis. So conservation of the presynaptic dopamine by retardation of its catabolism by monoamine oxidase is therapeutic in managing the symptoms of PD. Again, remember, we're just managing symptoms. Early use of non-selective monoamine oxidase inhibitors confirmed their therapeutic benefit in PD. But of course, because these are non-selective, they had a lot of toxicity because they will go for all the monoamine oxidases. Adverse reaction primarily involving cardiovascular stimulation as a result of peripheral monoamine oxidase inhibitors stimulation as a result of peripheral monoamine oxidase inhibition limited the utility of this drug. So that is very important for us to note that when we use non-selective, you will have a lot of toxicity. And no wonder you go for the highly selective ones, including selegiline. You go for the selective monoamine oxidase B. They do not go for A. It is synthesized by alkylation of the liver methamphetamine using 3-bromo 1-pine. So if you look at that, this is methamphetamine. So because of that methyl group and that methyl group, it becomes methamphetamine. If it had a hydrogen there, and of course the methyl group there, that is amphetamine. So we are alkylating. It's an alkylation process of methamphetamine using 3-bromo 1-propine. So that's position 1, position 2, position 3. So 3-bromo 1-propine, of course, 1 to show that the triple bond is at position number 3, because it could also be here. So it's the numbering is important when you give, of course, the UPAC name, because that it tells you exactly, gives you the exact position of the triple bond, and that alkylation will give you the selegiline. So when you look at selegiline, you can still identify up to there is actually methamphetamine. So this portion here is called Pagil. So you can still identify up to there as amphetamine, and you have added that portion, the 3-bromo 1-propine, to help us get the selegiline. The selegiline hydrochloride is pharmacologically active. Again, chemistry very important, but not necessarily the same isomer, because these are drugs that are working differently. So it is pharmacologically active. Pharmacologically active isomer is the R enantiomer. The monoamine oxidase B is found in high concentrations, as we have already said, in the brain, while A is restricted to the intestines and liver. So you want the A to continue doing what it's doing to avoid a lot of toxicity. An irreversible inhibitor of monoamine oxidase B by acting as a suicide substrate for the enzyme. When you talk about a suicide substrate, it is that substrate that has got the necessary optimal structure, and therefore it binds very well to the enzyme. And the enzyme here is monoamine oxidase B. And once it binds to that enzyme, it brings about, you can almost call the death. It binds that enzyme so strongly such that that enzyme cannot perform its normal tasks. And that is what we call, that's what we are calling a suicide substrate. It is that substrate which is so, it has the optimal structure to bind the enzyme. And once it binds the enzyme, and it binds it covalently, the enzyme is immobile. The enzyme is not free to go and bind and to go and bind dopamine, and therefore metabolize dopamine. So that's what we're calling a suicide substrate. It is converted by monoamine oxidase B to an electrophilic species that combines irreversibly with the flavin cofactor attached to the active site of the enzyme. So again, the enzyme, just as we talked earlier, there are enzymes that are also require cofactors. Remember, we detox the decarboxylase enzyme. We talked about the tyrosine cofactor. So that's just a cofactor. This one uses the flavin cofactor for it to have maximum activity. So it will to an electrophilic species that combines irreversibly with the flavin cofactor attached to the active site of the enzyme. So that is therefore you have the enzyme, the cofactor, and the drug. Now that complex is binding the enzyme so strongly so that the enzyme is not free to bring about its normal activity. Selegiline is selective for B type at therapeutic concentration. The monoamine oxidase metabolizes tyramine in the periphery, and it is not blocked by selegiline, avoiding what we call hypertensive crisis. When you look at tyramine, tyramine has structural similarity to adrenaline and noradrenaline, and therefore it can have an influence on the heart, contractility of the heart, the power of the contractions of the heart, and therefore bring about hypertensive crisis. But when you eat it, it's found in many foods like cheese and so on. But once you eat it and you have your monoamine oxidases, it will not persist. The concentration of tyramine in the periphery will not be very high because your monoamine oxidase is at work, and therefore it will undergo normal metabolism and it will not cause a hypertensive crisis. If you block the monoamine oxidase A, it means these compounds and others which can increase the blood pressure will not be metabolized in the periphery, and therefore they will precipitate what we are calling the hypertensive crisis. And that's why we are saying it is very important that you give drugs that are monoamine oxidase B selective, and they leave monoamine oxidase A to metabolize whatever needs to be metabolized. Tyramine does not cross the BBB. An important function of monoamine oxidase A, which remains intact with selegiline therapy, is that the enzyme provides protection from exogenous amines such as tyramine, having potent cardiovascular stimulant activity, as I have mentioned. So that is very, very important that you go for drugs that are selective for the specific enzyme so that you minimize toxicity. What is the metabolism? And just as we have seen, selegiline is made from methamphetamine. That means when it comes to be metabolized, it can't release methamphetamine in the body. And of course, you do know methamphetamine, amphetamine, these are drugs that can cause CNS stimulation. So those are some of the side effects that you can observe when patients that are taking selegiline. So because of the release of amphetamine. So if you look at that, it's selegiline or N-propagil. This is a group that we are calling propagil, that group there, N-propagil methamphetamine. So N-propagil methamphetamine, you can see this is actually methamphetamine, and it can be metabolized again through mixed function oxidases, especially cytochrome 2b6 to desmethyl selegiline. All that has happened is oxidative N-demethylation, oxidative N-demethylation, whereby that it is catalyzed by mixed function oxidases, the methyl group is left, and you get N-propagil amphetamine. You can see this is amphetamine now. You have an NH2 there, and that, of course, is the propagil group. So N-propagil amphetamine, and then that can further undergo metabolism, whereby, again, look at this is an alkyl group. Again, you can get oxidative N-dealkylation, this time also catalyzed again by mixed function oxidase, and you remove the whole of that. And if you do so, the resultant drug is amphetamine. So that's one danger of using selegiline, in that in the body in vivo it can be metabolized into desmethyl selegiline or L-propagil amphetamine, and even amphetamine and even methamphetamine can also be metabolized to methamphetamine, because if you remove oxidative N-dealkylation of that group, it will give you methamphetamine. So it can be metabolized to methamphetamine, to amphetamine, and these are compounds that are even abused because they bring about a lot of CNS activity. And then that, of course, that is a line of toxicity. That is selegiline. The next one, which is also a monoamine oxidase B selective inhibitor, is losargiline. So again, you can look at that structure a little bit more. I don't know whether it is simple or it's almost the same. Not very different. So you have that structure of losargiline, and one of the things that we note, again, we can note, again, look at that, and then you go this way, and you see what to expect. Phenyl ring, and of course, this one has only one. This one does not have the ethyl. This has the methyl chain, but with tension of activity. So this is a bit different from the others, because you can see this is only one carbon. All the others are being separated by two carbons, and therefore have a lot of similarity with the dopamine. But here, the separation is with only one carbon, but still retaining activity. It's a highly potent, selective, irreversible. That's again very important. Mitochondria monoamine oxidase B inhibitor. It inhibits striatodopamine metabolism, thereby providing relief from motor symptoms of PD. Again, it is just providing relief from the symptoms. There is no healing here. It is relieving the symptoms. It may be dosed once daily, and unlike selegiline, it is metabolized to non-amphetamine compounds. So that's important that it will not cause CNS side effects, because when metabolized, it does not produce amphetamine or methamphetamine. In a large clinical trial, rosagilin has proved effective, safe, and well tolerated in early PD as monotherapy. So you can't use it for monotherapy. Again, we are using it. It is blocking the monoamine oxidase B selectively, and therefore increasing the concentration of dopamine in the brain. Of course, we have said the advantage is that it does not form methamphetamine or amphetamine on metabolism. Rosagilin should be rosagilin, undergoes extensive hepatic metabolism and almost complete biotransformation in the liver, primarily again by the cytochrome P450 enzyme or the mixed function oxidases to form 1R aminoidane. This is the 1R aminoidane, that is a drug. Again, because we look at the drug, and of course this group here, the Pagel group there, again can be removed through oxidative N dealkylation, and once that is removed, you will just get this group there, N, an amino group there. So that can happen, and that will give you the 1R aminoidane, which is a major metabolite. Also, this compound can undergo oxidative hydroxylation, and mainly of the cyclopentane ring, can undergo oxidative oxidative hydroxylation of the N-pentane ring. And this is basically because of that nitrogen. That nitrogen will push electrons in the system, and this group there, or that carbon, can have some negativity and easily undergo oxidative hydroxylation. So this is also another product. So that's another product, which is 3-hydroxy N-propagel 1-aminoidane. So this is just another of the metabolic products, and you can see we have said you can also get 3-hydroxy N-propagel 1-aminoidane and 3-hydroxy aminoidane. 3-hydroxy aminoidane is now when this compound undergoes oxidative N dealkylation, and you leave that, and already it has the hydroxyl group at position number 3. So we are numbering 1, 2, 3. So I think also it's easy to be able to understand the metabolic processes of this drug, because they are also structure dependent. The route of metabolism is structure dependent. And this is a metabolism that we already looked at is for selegiline and for the rosagilline, whereby we are saying we have the N-propagel R aminoidane, as we have already explained. You see, this is the one, the stoichiochemistry or the orientation of this group, or of the N-pageline group. The orientation of the N-pageline group should be the beta orientation, and that gives us the R conformation, which has the higher activity. If it carries the alpha orientation, it will give us the L aminoidane, which we have said has minimal activity. So we are only saying that this drug can be easily metabolized through oxidative hydroxylation, not hydroxylation, oxidative dealkylation, where you lose the propagel, you lose the propagel group, and of course you get the aminoidane. And that we had already mentioned, that is a major metabolite, but we also say this compound can also undergo hydroxylation at position number 3, and then of course also the hydroxylated metabolite can also undergo oxidative N dealkylation. But the main metabolite, as we had said, was the aminoidane. So when you look at these two, because of the differences, so the toxicity of these drugs is because of their route of metabolism. So toxicity of selagiline is because of its route of metabolism, and therefore the rosagilline is slightly more, it is safer than the selagiline because of the CNS stimulation. So this is the same thing that we have already looked at. So we have this, we had looked at selegiline can go to this methylselegiline, it can go to the methamphetamine, LP hydroxy and methamphetamine, so that also can go hydroxylation. It can also go to L-amphetamine, L-para-hydroxyamphetamine, and then the rosagiline can go to amino, indane, or N-acetyl. This is not acetyl, this is even the same compound. So it can go to amino, indane, and also if it's N-acetyl, it means this is acetyl transferase, and this is a group which will be N-acetyl. So that was missed out. So it will be C double bond O H3. That will be the N-acetyl. So it can also undergo acetylation, N-acetyl amido transferase, and that will give you that the NH, the amino group will be acetylated, and you can get N-acetyl amino indane, which of course will have much lower water solubility, termination of the pharmacological activity. So those are some of the metabolic processes that the selegiline can undergo, whereas the rosagiline, as we have talked about, already said mainly will undergo. Actually, we have also said the rosagiline, and we have also talked about the selegiline, and of course, we have said why the toxicity is there for selegiline and not for rosagiline. So again, when we look at the mode of metabolic pathways, have some connection with the drug structure. That is the monoamine oxidase B selective inhibitors, and then we can also have the COMT inhibitors. Remember also the catechol-methyl transferase. Transfers is an enzyme that catalyzes the transfer of a methyl group to position number 3. Therefore, again, of dopamine. Therefore, again, if you block this enzyme, then you will slow down the metabolism of both dopamine and, of course, also of L-dopa. Inhibition of catechol-methyl transferase activity in both the periphery and the CNS enhances the bioavailability of L-dopa. And we have 2 drugs. We have the tocapone and entacapone. And the tocapone has high. It has both CNS activity and peripheral activity. Entacapone has mainly peripheral activity with minimal CNS activity. So of course the tocapone is a better one. Tocapone, an inhibitor of COMT in both the periphery and the CNS, higher CNS activity than peripheral activity. Entacapone, less potent catechol-methyl transferase inhibitor and less readily distributed in the CNS. The nitrocatechol structural feature of both drugs confers affinity for the active site of COMT. If you look at the structures, this is tocapone. You can see it has that bit. This is the one we are saying is the most active, and then we have that entacapone. Again, it has that. So that's why we're calling it the nitrophenyl group is responsible for binding the receptor, because you can see it is in both drugs. Nitrocatechol structure, we have seen it's in both drugs. Nitrocatechol structure feature of both drugs confers affinity for this drug binding the site of COMT. Remember, this site is bound by dopamine. So the only thing that you have put to these drugs is added the nitro group, and how somehow that nitro group also increases the affinity of these drugs to the receptor compared to the dopamine, and therefore they bring about competitive inhibition. If you look at these drugs also, if you look at tocapone, we have also this group. So the one which is responsible for binding the receptor is that portion there. So this other portion on this side, which we can call, this is Tolwell group. I can call this a Tolwell group. That group is responsible for the antagonism. Remember, these are drugs that will bind and block. Blocking meaning they will not trigger pharmacological activity. So we are saying this also bulky group. On this side, we also have this bulky group here, which we can say it includes a dimethylamino, So if you look at this group here, there's a dimethyl amino, sorry, a diethyl amino group there. There is also an alkene there, and there is also a ketone there. I tried to get a name for it because we can consider it's 1, 2, 3, 1, 2, 3 carbon atoms. That is the longest chain, so that's a derivative of propane. But because it has a double bond and it has a ketone there, then we can call it propinone. Rather than propene, we call it propinone, and then we can consider this group and that group a substituent. So I think I called it N-diethyl because that's an ethyl group. That we can say that's position 1. Say here that is position 1, position 2. So we can't say N-1, N-diethyl, N-diethyl amino, and then position 2 cyano, propane 1, propene 1 on, propinone, and the group, this group here. So there is propene, actually there is propene at position 1, 2. So propene, before you get to in, you get prop, and then you put 2, and then you put in. That shows the double bond at position number 2. And then as you go to the propanone, so on, and there will be position 1, 2. So that's 2, 1, plus position 1. So that's position 1, position 2, position 1, position 2. So the double bond, since we are counting from this side, the double bond will carry the position 2, and the cyano group also is in position 2. The propanone is in position number 1. But I just called it the general name without indicating the position perhaps of those substituents, but one can be able to put the groups where the exact position, because as I have said, we count from the side where we have our carbonyl group, which is position number 1. The ketones carried fast priority compared to the amines, and that's why we will name it as a ketone rather than an amine. So we are going to consider that as a substituent and at position number 1, and then cyano group at position number 2, and of course also, remember when we number the double bonds, we start with the lower number also at position number 2. So we are also saying, all I want to say is that this group also, so this group here, which we have called the Tolwell group, and this group here, they are responsible for the antagonistic activity or binding the receptor family, preventing the agonist from binding, and of course not being able to trigger a pharmacological activity and hence giving us antagonist activity. This other group, which called the nitrocatechol, you require that area for recognition of the receptor. Once you recognize the receptor, of course there is binding or there is interaction with the receptor, and then the other group also contributes in that it will help also to anchor this drug onto the receptor, but not allow for any pharmacological activity. So I hope that is clear. So we are therefore saying the toluene, the dimethylamino cyano-propinone moiety produce an antagonistic action. Tocapone has been characterized as a tight fitting. Remember, we say tocapone has both peripheral and also CNS, well distributed in the CNS, and also in the periphery, has activity in both areas. It's more active than the entacapone, and that's why we are saying it's characterized as a tight binding. When we talk about tight binding, these drugs binds more tightly than the agonist, but do not have the ability to trigger pharmacological activity, but they will prevent, as long as they are binding, the agonist can't bind, and no wonder antagonistic activity. So they are tight binding, competitive inhibitors of the catechol methyltransferase, because once they bind, bind that enzyme, then the normal substrate, which can either be L-DOPA or dopamine, cannot bind that receptor, because these drugs are binding a little bit more strongly, have a slightly longer duration of action, and therefore will inhibit the metabolism of both L-DOPA and dopamine by the catechol methyltransferase. Entacapone has the stereochemistry about the double bond. Remember, again, when we have double bonds, we have the which was the other, we have the E, which is the other one, remind me? The Z. We have the E and Z stereochemistry. And of course, remember the E stands for the trans and the Z stands for the cis. So where we are saying you can have the big groups on the one side, the same side, or you can have the big groups on opposite sides. So let us not confuse R and S. S, E, and Z is geometrical isomerism. R and S is optical isomerism. And that is, of course, a big difference, both of them being stereo isomers, because they bring about differences in the stereo arrangement, in the spatial arrangement of these molecules in air, but one of them around a double bond, another one being determined by the orientation. So one is because of the orientation of the groups, whether they are beta or alpha, whereas the other one is the groups you have on the same side, whether you have the groups on the same side or on the opposite side of the double bond. So it's important for us to remember that. The major metabolite, entacapone, has the E stereochemistry about the double bond, and the major metabolite of entacapone is its Z isomer. So again, an inversion of the isomer, and when you have that, sometimes you also lose activity. Therapeutic activity results from increased bioavailability of L-DOPA to site of action, because of course it's not being metabolized. And again, also there is some it reduces when you find the activity of these drugs. It reduces the formation because the L-DOPA is not being metabolized. You have lower concentration of this compound, of this metabolite, which is called the 3-O-methyl L-DOPA. The 3-O-methyl L-DOPA has been found to be very toxic. It is responsible for some toxicity. So once you decrease the metabolism of L-DOPA by blocking the COMT, then also you reduce the formation of the potentially toxic metabolite 3-O-methyl DOPA, and that is why you have better therapeutic activity, because you have reduced toxicity and yet you have increased L-DOPA. So that's what we are saying. The therapeutic activity results from one, increased bioavailability of L-DOPA, reduced toxicity of this metabolite 3-O-methyl L-DOPA, because it will be formed in much lower concentrations because you have blocked the catechol O-methyl transferase. I hope that is clear. This we had already looked at. And now we are saying you have the L-DOPA, and when you have the L-DOPA, remember L-DOPA is dihydroxyphenyl alanine, then R is a carboxylic group. When you have dopamine, R is a hydrogen. So you can have the catechol methyl transferase, and it uses the methionine, which has a CH3 iodomethionine, which has a CH3, and of course you have the enzyme, and you get the conversion depending on what group is here, whether it is L-DOPA or it is dopamine. If it is L-DOPA, you get the 3-O-methyl DOPA, 3-O-methyl dihydroxyphenyl alanine, which we have said can also bring a bit of toxicity. And if it's a hydrogen, of course, you get the 3-methoxytyramine when R is a hydrogen. And all we are saying, this is what we are blocking. These drugs, tocapone and entacapone, will block this process. And once they block that process, it implies that you will have reduced a metabolism of both dopamine and also L-DOPA, having lower toxicity and having higher concentrations of the dopamine, and hence, of course, giving us a balance between the dopamine and acetylcholine, and therefore relieving the symptoms. Again, it is, unfortunately, it's a progressive degenerative disease. So it will continue progressing, of course, until to the end. But in the lifetime of that person, remember, we talk about quality life. We talk about a quality life. That's all we are trying to give these patients. You give them a quality life. They have less rigidity. They have less tremors. But unfortunately, the disease will continue progressing. And unless they take the drugs, they will have those terrible symptoms. And that is the only danger. And of course, as we have learned, there will be tolerance. And we did mention that these patients, sometimes they are on L-DOPA, but they'll still have the off periods, whereby even on the drugs, they are still having the symptoms. And therefore, it is a disease which it is a disease which it's a difficult disease. It is a disease for which even us as a medical personnel, when we see these patients, we need to handle them with a lot of love, a lot of understanding, at least for us to help them have a better life. And I think that is my last slide on anti-Parkinson and PD drugs. Is there any question? I might not have studied all of them because, of course, it could be very many, but I've tried the best I can to pick most, at least an example of each of the groups so that you can be able to understand how that disease is managed. Any questions? Are we okay? Any questions? If there are no questions, we move on. And as I have said, the next group of drugs is even much more simpler as far as I'm concerned, but I hope you will also find it more simpler. So we move on to the general anesthetics. And again, all of them, we call this unit CNS, I think, 1. So most of them are CNS drugs. They are working through the mind, but they do not really have any connection. They just pick different drugs, put them in the same category, although they have different modes of actions, they have different effects, they have differences in their therapeutic indications, but they work through the mind. So the connection of these drugs is that they are central nervous system drugs. So that is the only main connection that they have. So we look at the general anesthetics, and what can we say is a general anesthetic? What would you define as a general anesthetic, class? Can I get an answer? What is a general anesthetic? If we have another 1 hour, we can be able to cover quite a lot. What is a general anesthetic, class? What's a general anesthetic? Can I get some answer through the public chat? What would you say is a general anesthetic? Have you done them in pharmacology by any chance? Hello, hello? Are we there? You are so quiet. Are we there? Tuko? How many are we supposed to be? We are only at 7 today. Jacinta? Jacinta? Hello, hello. How many are we supposed to be?
We are supposed to be around there, that 5:36.
Oh, that 5:36. Oh,
Yeah.
the class, therefore, so we are okay. The class is not very huge. I think even the first, somehow I think even the third years, almost the same number. One of the third year class. All right. So what can we define as a general anesthetic? I can see somebody writing. So I've said the first inhibit pain perception, loss of consciousness, and that is very good. Indeed, one of the characteristics is a person who loses consciousness. Drugs that bring unconsciousness in medical procedures, and of course, because of bringing the unconsciousness and also pain relief, then you can use it. You use them as general anesthetics. You use them to do major operations. This person is not dead, but they're unconscious and they cannot feel the pain. So these drugs will bring analgesia. They bring analgesia. Of course, you normally give them with other drugs in combination of many other drugs, like muscle relaxants. You add muscle relaxants, you add them there so that this person also, as they are being operated, their muscles are not stiff, but they are relaxed. And of course, immediately after, because some of these drugs have a lot of toxicities like nausea and vomiting, you also put anti-nauseating medications. You also do pre-medication before you give these drugs and so on. So we look at, of course, I'm trying to look at the pharmaceutical chemistry in it. There isn't really so much, but we do look at what we can. So we will also have some pharmacology as we go along. So we are looking at general anesthetics, and we can see general anesthetics are a group of drugs that produce loss of consciousness and therefore loss of all sensations. There's absolute loss of sensation is termed as anesthesia. So they have loss of consciousness and loss of all sensations. They bring about descending depression of the central nervous system, starting with the cerebral cortex, the basal ganglia, the cerebellum, and finally the spinal cord. So you are completely unconscious. These drugs are used in surgical operations to induce unconsciousness and therefore abolish the sensation of pain. So we are using them as general anesthetics. They cause unconsciousness, and because of that unconsciousness, you also do not have any pain. What are the stages of general anesthesia? Because you will do this more about, I expect if you have studied this, studied a lot of it in pharmacology. I'll just mention in passing, when an inhalation anesthetic is administered to a patient, some of the following well-defined stages are produced by increasing the concentration of the agent. You have number one, the stage of analgesia. This is where now the drug acts as an analgesic. This is a period from the beginning of anesthetic administration to the loss of consciousness. The patient progressively loses pain. This stage is also called the stage of analgesia. So that is the first stage whereby you bring about the analgesia. Then stage two, stage of delirium. This period extends from, remember, you are increasing the concentration of these drugs slowly by slowly. This period extends from the loss of consciousness through a stage of irregular and specific breathing to the re-establishment of regular breathing. So initially there will be a lot of irregular breathing, but then that's why you have to have an anesthetist. An anesthetist is a physician who is very well trained on administration of these drugs, because there must be a proper control of these drugs, and of course also the oxygen, so that this person is very stable and of course can allow for operations without any problem. So therefore there will be that stage of irregular breathing, and then you establish the regular breathing. The respiration is normal and regular. The patient may laugh, vomit, or struggle, and for this reason it's called the stage of excitement, and that's why we're calling it delirium. Patient may laugh, vomit, or struggle. This reason is called stage of excitement. But finally, of course, with the trained anesthetist, they will control all those symptoms, and the patient is stable, and therefore they can. So at that particular point, they are not yet completely stable for operation. They require to just go slightly more, and we go to stage three, which is a stage of surgical anesthesia. In this stage, excitement is lost, and skeletal muscle relaxation is produced. Of course, as I said, you also do give them the other muscle relaxants. Most types of surgeries are done in this stage, because there are some of these anesthetic drugs that do not cause any muscle relaxation. So more often than not, you give in addition with muscle relaxants. For those which do not cause, there are those which you cause unconsciousness plus muscle relaxation, and therefore you do not require you can just operate. Most types of surgeries are done in this stage. So the stage three. Now, if you exceed stage three, then you're going to kill that patient. Stage four, stage of medullary depression. Overdose of the anesthetic may bring the patient to this stage. Respiratory and circulatory failure occur in this stage. If you talk about respiratory and circulatory failure, then now we are talking about death. So that is why, as I said earlier, that's why you have that whole degree, whereby after you do your MBCHB, you go now back for training so that you can become an anesthetist. You become an anesthetist so that you know how to work in theater. Your work is just controlling those drugs and observing the symptom, the signs and symptoms in the signs and symptoms in the patient, so that you're very, very careful. You do not go overboard, because as you can see, if you go overboard, there will be both circulatory and respiratory failure, and that means death. So one has to be very, very careful. Again, you have to be very careful so that you do not give too little and this patient starts waking up and you're not yet done with the operation, because again, that will be very painful for the patient. General anesthesia involves administration of different drugs, as I have said, and we are going to do this a lot in pharmacology. You have pre-medication, you have inducing agents, and you have maintenance agents. Especially when you come to look at the anesthetics, you find that there's those which work very quickly, like the barbiturates. But not unless if you continue giving the drugs, you cannot. They also undergo depotorization. They are removed very quickly, and therefore you would require some other drugs to maintain the anesthesia. So we are talking about pre-medication, so that you make sure the patient, you remove the fluids, you give pre-medication, so that now, as you give these drugs, this patient is unconscious, so that now you are sure they will not produce a lot of secretions which can choke them. You can also give drugs that will prevent them from vomiting, because the vomiting will also choke them, and that's what we are calling the pre-medication. And then, of course, as we have said, there are those anesthetics, the general anesthetics you use as induction agents, and those ones that you can use to maintain the anesthesia up to the end of the operation. Pre-medication, that is prevention of bradycardia, bronchial secretions, and muscle spasms. You can use benzodiazepines, you can use narcotic analgesics, you can use anticholinergic drugs, you can use skeletal muscle relaxants. All these are drugs. I believe you've studied them. So in each of these class, please put an example of drugs that you can use. We have looked at narcotic analgesics that you can use in theater. We have mentioned them. We studied them with you. The fentanyls and so on. So you can use narcotic analgesics, you can use anticholinergics. So make sure you know an example of each of those drugs that you can use for pre-medication. Inducing agents, these are drugs that you can use for induction, and this is where you especially use the intravenous anesthetics like the barbiturates. You have the pentosan sodium, methotrexate, and non-barbiturates you can use propofol and ketamine. Of course, these drugs will have different toxicities and, of course, different prices. So you will choose depending on what kind of operation you are doing. Maintaining anesthesia, and again, sometimes it depends on the type of hospital, the level of hospital, because as I have said, some of them are quite expensive. Maintaining anesthesia, and this is normally done through inhalation. So you have already given the intravenous, so that because you want a rapid onset of the anesthesia. Rapid onset, and that's why when you go to theater, they tell you count 1, 2, 3. By the time you are getting to 3, you are off. So it's rapid, very smooth. You want smooth and rapid without incidents. And then after you have done the induction, now you want to maintain that person in the anesthesia. And that is where we can use now the inhalation anesthetics. And you can have the halogenated hydrocarbons and ethers, halogenated hydrocarbons like halothane or like ethers, enfluorine, enfluorine, there is isoflurane, and so on. You can now use them to maintain the anesthesia. And there's also nitrous oxide. Antiemetic agents may be required post anesthesia, as we had said. Sometimes when the person wakes up, you can give them anti-nausea agents. I think you don't give them, as I had said, you don't give them pre-medication. We have seen the pre-medication. We have noted what you give. You give the benzodiazepine, you give drugs to prevent bradycardia, bronchial secretion, and muscle spasms. And then post operatively, you can then give the antiemetics to prevent this person from vomiting. Now we do the classification. As I see, there is very little of the structure, structural classification, because this is one class of drugs where they have very different structures. The drugs have very different structures, because what is really needed for these compounds is for them to have good lipid solubility, that they can get into the brain and they can sit on the nerve and block the nerve. Once they sit on the nerve block the nerve, then they block or conduct the activity of the nerve, then you will have the anesthesia. So you find that there is very little SAR in terms, not like the way we look at the penicillins, we look at even the narcotic analgesics, they have very little SAR. What you require is to have adequate lipid solubility, and that the drug has rapid onset of activity. Of course, it gets to the brain, it brings its activity, it has minimal toxicity, and then it leaves. And definitely it blocks, it sits and blocks the nervous conduction. It can do that, as we are going to see, in various ways. So the general anesthetics may be classified according to their nature, whereby we are talking about volatile or non-volatile at room temperature. They are the volatile inhalations, general anesthetics. So these are volatile. They might be liquids at room temperature. You add just a little bit of pressure, temperature, and you volatilize them, and then the person inhales. So volatile inhalation, general anesthetics, they're administered by inhalation and further subdivided into, you can have the gases, where you have the cyclopropane, ethyl chloride, and the nitrous oxide. All those are in terms of gases. Then you can have the liquids, which are volatile liquids, and you have the ethers like diethyl ether, you have the halogenated hydrocarbons like halothane, you have also chloroform. You know, chloroform has been used badly by many thieves, because the guy comes to your house and sprays chloroform, I can tell you, there will be a lot of problems. They will just break in everything they want. They'll break in and take everything they want, because of course chloroform will make you sleep. And that's why we say, when you train you for pharmacy, we want you to be honest people. We want you not to be people who can be used by criminals to execute terrible things. Because some of the drugs we study, some of the knowledge you have, is knowledge that can be wrongly used. It can be disastrous. And that is what some of the people are doing. Some of the very professional people, be it doctors, be it as pharmacists, even nurses, they know all this information. Then they give it to the wrong people. They even give the drugs to the wrong people. One wonders, why would somebody do that? So it is very important that for us as professional people, when we train in these things, we train for the betterment of humanity, not the reverse. You are not trained to know these drugs, to know what they can do for you to go and use them against humanity, to enrich yourself. And let it never be, because of course the evil ways always have a terrible end. You might think you have gone through it because you have succeeded. You as a person, you go through your life successfully. You have so much in life, but for what? If you have acquired it the wrong way, you will still live it in this world. Then after that, remember, we have generations and generations. And the Bible has said, in terms of the very sick people, remember when people come to you, they come to you when they are in the lowest, at their lowest. Because when you are unwell, you have diarrhea or you have whatever you have, you are usually at your lowest. So you are going to somebody who is supposed to assist you, who is supposed to help you, talk to you nicely, not the way people talk to people at the window. Talk to you nicely, handle you with love and with care. So you are very important people. But that knowledge that you have, let me tell you, can also be very important or very disastrous. Once you graduate, because you will graduate very soon, once you graduate and you'll take an oath, it is up to you, my dear students. What will you do with the knowledge you have? Will you be out there selling diazepam to anybody who is asking for diazepam or hypno and what have you, so that these people can go and lace other people's drinks? Will you be there selling anything without a prescription, or will you observe the profession of pharmacy as it has been taught to you? I thank God that some of us, I cannot say I am rich, but I tell God I have enough. I have enough to keep me going in this life, and even something little to live. But I have not practiced. I have defended the profession of pharmacy. So even if you defend the profession of pharmacy, you might not get rich very quickly, but one day you will have enough for yourself and for your family, and you leave a good legacy. So I am requesting you that as you go out there with all this good and dangerous knowledge, please apply it wisely for the glory of God and for the legacy that you leave behind, that nobody also will do what you will do to other people's children, to your own children, or to the children of your own children. Because well, they say what goes around comes around. What you might do to others one day might happen to your own. Might be there, that time you might not be there, but it could happen. So let us guard our professions. Let us be professional in everything that we do. Let money not be our motivator, but let good practice, good pharmacy practice be what motivates us, and finances, riches, and cars and everything else will follow suit. One day they will come at the appropriate time. So when you go out there, remember, I told you those words. Remember, you are responsible. You can see what is happening to very big institutions like Kemsa, mismanaging drugs, mismanaging even when we had COVID. Nobody cares about the dying. You want to be counted to be one of those people who can stand up to be counted, having gone through JQuat, having had the opportunity to be trained well, to be even mentored well. Will you stand up to be counted, or will you join the crowd and just be a thief for your own benefit? Now, I'm telling you, it can't be. It's very painful because many of our people, even in hospitals, are not dying sometimes because of the diseases. It is because drugs have been stolen, wrong diagnosis, wrong drugs, because perhaps you came in the morning and you are high, you cannot. Anyway, it's up to you, my dear students, that one day when you sit before your God, that you will be able to say, I fought, I did it well. And I can attest, I can stand and say, I practice my profession to the end. For both yourself also, some of our pharmacists end up taking these drugs. So let us continuously pray that the Lord will walk with us, or God, whether it is, you will walk with us along the way to do the right thing. So these drugs, as we study them, are terrible. And some of these, even these anesthetics, some of them are the ones that are being used there. You find that these people have these drugs in small bottles, and they have some handkerchiefs. They put those drugs in those handkerchiefs. And they even bring near you just to smell them, and you are gone. Just smelling them, and you are gone. So let us be careful that we do what we have been taught, because I know you have been well taught. So we are looking at the classification. They are the liquids which we are using. They are used as inhalations, and you need to inhale very little. You know, like in theater, you're inhaling for purposes of being operated. Well, if somebody wants to mess you, they need a very small dose, and of course, you will go unconscious, and they will do whatever they want to do. Classifications too, according to the nature. You also have the non-volatile or the intravenous anesthetics, and they are non-volatile at room temperature and administered by intravenous route. And of course, you know, the intravenous route is gives us the most rapid activity, because you are giving it directly into the blood supply. And of course, these drugs, as we are going to see, the barbiturates, they also have very high lipid solubility. So when they hit the brain, they will also move out from the circulation, move out from the brain, and go to the surrounding tissues. And therefore, they have also a very short duration of activity. So you have the barbiturates, you have the pentasodium, methohexosodium, and you have also the non-barbiturates, where we look at ketamine and also propofol. So that's one classification. And as I have said, it's difficult for us to do a general classification as per structure, because there is no, apart from like now the barbiturates, they really do not have a lot of structural resemblance. But of course, within a certain class, like when we say the non-volatile, like the barbiturates, when we discuss the barbiturates, of course, do have structural resemblance. But most of these drugs, and of course, even when we look at the the halogenated ethers, when you look at the halogenated ethers, within that small class of the halogenated ethers, they will have structural resemblance. But all the general anesthetics definitely will not have a structural resemblance. Combination. So we have talked about the classification as per route of administration. So we have the gases or vapors or volatile liquids that are inhaled in a mixture with air or oxygen. We have, of course, also said the intravenous anesthetics. We have agents that are psychologically well tolerated, useful as induction agents for inhalation anesthetics. You can also have the combination anesthetics, whereby you combine combination therapy to increase the effectiveness and decrease the toxicity, because it will also allow you to decrease the dose that you give at any particular time. Administration of minimal doses of individual drugs to achieve certain goals of anesthesia with optimal therapeutic outcomes and minimal toxicity. So we can have, so when we look at the classifications as per, that was as per nature, as per route, we are having the inhalation and the intravenous, and then of course you have the combination, because we have said we can have those for induction, but they will not go far. And then you can have the ones for maintenance. And these are some of the examples. Of course, you can have the halothane. If you look at the halothane, you can see this is a halogenated hydrocarbon. You can see it is a hydrocarbon, but it is halogenated in that it has bromine, it has chlorine, and it has fluorine. It has actually the three main halogens. Then you have enfluorine. Again, you can see enfluorine has chlorine, has fluorine, and it does not have bromine. And then we have isofluorine. If you look at enfluorine and isofluorine, you see these two are the same in terms of their condensed formula. If you get the condensed formula of enfluorine, it is the same as that of isofluorine. Their difference is in the positioning of the atoms, the positioning of the atoms, whereby we can say enfluorine and isofluorine are constitutional positional isomers. They only differ in the position of specific atoms, but their condensed formulas are the same. Of course, then you have desfluorine, it will differ in the number. So you can see this one has chlorine. Desfluorine has no chlorine, it has only fluorine. The isofluorine has both fluorine and chlorine. Of course, it's same as fluorine, because we have said they are constitutional isomers. Then we have now the halogenated ethers, and you can see we have methoxyfluorine, diethyl ether. We had mentioned the diethyl ether. We'll have ethyl on both sides. That again is a non-halogenated ether. And of course, we have the halogenated ethers, which we've already said, enfluorine, isofluorine, and desfluorine. We have cyclopropane. This is just a cyclic hydrocarbon, not much used because it is it can burn very, very quickly. It is very explosive, can burn very easily because of the strain. You can see it is a three-membered cyclic ring, very explosive, and for sure, because of the safety of our theaters, you do not want to use compounds that are highly explosive. So characteristics of a good general anesthetic. Again, I do believe you do this, a lot of this in pharmacology, and I do general anesthetic should possess the following characteristic features. It should be inert, it should be potent and non-inflammable, it should not be it should be non-irritating to mucous membrane, it should produce rapid and smooth anesthesia, rapid, smooth, very important. It should produce analgesia and muscle relaxation in addition to anesthesia, so produce analgesia and muscle relaxation. That sometimes does not happen. But if it does not happen, then you can go for other specific drugs that can produce those characteristics. But if you could have one that could produce all that, all the better. And as I've said again, this you should be able to cover a lot of it in pharmacology. It should not produce severe hypotension. It should not produce nausea and vomiting. It should be compatible with adjuvant drugs used in anesthesia. We have said you can add other drugs so that you get the best state during the surgery. It should be economical. In other words, it shouldn't be very expensive, but we call them cost effective, because you can have something cheap that is not effective. So when we talk about economical, it should be cost effective. It should be stable to heat, light, and alkaline. So these are some of the characteristics that you would require for an ideal general anesthetic. But of course, there is no ideal general anesthetic. Most of them will have these characteristics and will be devoid of some others, but of course, you pick the one which has the best. Of course, none, that's why we are calling it an ideal. None of the general anesthetics will have all those ideal characteristics, but of course, you can pick one which is closest or which has minimal negative characteristics. Mode of actions, as I have said, most of these drugs just block. They block conductance, nervous conduction. They can do that through various ways. So mode of action, general anesthetic target the ligand-gated ion channels. That's one way they work and produce an anesthetic action. So remember, for nervous conduction, you must have those ion-gated ion channels. You have the calcium ones, you have the potassium ones, you have the chloride ones. The calcium ones are excitatory. You have the chloride ones, which are inhibitory. So if you have a general anesthetic which can excite the inhibitory, which are usually the GABA ion channels or receptors. So if you have one that can excite or trigger the inhibitory ion channels, then you will have depression. If you have one which you block, so there are those two ways. Either you excite the inhibitory ones, or you block the excitatory ones. If you block the excitatory ones, then of course there will be depression, because anesthesia and having unconsciousness is just a block of the nervous conduction within the brain. So blocking the NMDA, which is the N-methyl D-aspartate, and glutamate controlled channels, these are excitatory. The NMDA and the glutamate control channels are excitatory. The above receptors in the CNS are activated by the excitatory amino acid neurotransmitter glutamic acid. So you can see the NMDA are excitatory. So if you block them, then you will block nervous conduction. Agonists, the activation opens channels, allowing potassium ions to flow to the extracellular fluid and sodium and calcium ions to flow into the nerve cell. So into the nerve cell and out. And that's flow of ions. Remember, flow of ions can conduct a current. And indeed, nervous conduction is just that small current that is conducted. And as though that flow occurs, the information is moving. So that nervous conduction is a way of movement of the information that you require. So we are saying those channels, if you block, therefore, these channels, you will block the agonist activity. The increased intracellular calcium ions activates the liberation of nitrogen dioxide, which causes alertness or consciousness. Antagonists such as ketamine, which blocks the NMDA receptors, causes CNS depression. Because remember, as we have said, these are excitatory ion channels. So when you block them, then you will cause depression. And one of the drugs that does that is ketamine. You're still on the mode of action. Then you have the other channel, the other receptors, which are also gated channels. And we have the GABA receptor gated chloride channels are the most important sites and open to perform, again, the inhibitory action. So the GABA receptors are inhibitory in nature, and the barbiturates and the benzodiazepines are really not used as a general anesthetics, but times you can use them in combination for what we did mention, the pre-medication. Then you find that these ones bind an allosteric site, not the GABA site, not where GABA binds. GABA is gamma aminobutyric acid, not exactly where GABA binds, but there is a site which is just near, and they bring about the same effects as GABA. And GABA is an inhibitory neurotransmitter. Barbiturates stimulate by binding an allosteric site, the inhibitory neurotransmitter system in the brain called the gamma aminobutyric acid. So they bind an allosteric site where this binds. Barbiturates increase the amount of time chloride channels are open, consequently depressing the central nervous system. The benzodiazepine increase the frequency, or the frequency, not the frequency, but yeah. So these ones in amount, they increase the amount of time. The other ones increase the frequency at which the chloride ions, at which the channels open. Whereas these other ones increase the amount of time, so they prolong the time. The other ones increase, I think, the amount which is flowing, how much is flowing out, and therefore that's the benzodiazepines, and therefore also will bring about a depression, because they will increase the amount of chloride down that is coming out, whereas these ones will prolong the time. So these chloride ion channels will be open for a longer time, so chloride ions will flow for a longer time. The other ones, they might flow for a short time, but the amount that is flowing out is increased, and therefore will still cause depression. The dinitrogen oxide and ketamine, because you see there's a difference between the other one. This is the drug, dinitrogen oxide. The other one is the gas. Nitrogen dioxide is a gas. So the dinitrogen, this, so please note, this is the nitrous oxide, N2O, as opposed to NO2. NO2 is the gas. So N2O and ketamine do not affect the GABA or glycerine-gated chloride channels, but they selectively inhibit the excitatory NMDA type of glutamic acid receptor, which belongs to calcium-gated channels in the neurons and leads to neuronal hyperpolarization. And when you get hyperpolarization, again, the neurons will not conduct. They will not conduct. They will stop having nervous conduction. They will have a blockage because of hyperpolarization. Because remember, once you excite the neuron, it must go back to its normal state, and so that it can conduct. If it remains hyperpolarized, then of course it cannot conduct any cannot do nervous conduction. Inhaled anesthetics, like you have nitrous oxide, so the nitrous oxide, the N2O, I hope that was the same, yeah, nitrous oxide, which is the N2O, which is also called as the laughing gas. Why they say that when you're given this, you can continuously laugh. A colorized gas exerts low anesthetic effect, mixed with oxygen and ether or halogen, as deep anesthetic cannot be achieved with it alone. Remember, we talked about combination anesthetic. So you find the N2O does not exert low anesthetic effect. So it requires to be in mixture. So you mix it with oxygen, you mix it with halogen, and it becomes to give you deep anesthesia and good analgesia and minimal toxicity, but poor muscle relaxant effects. Remember, we said you will have one, but not you might have one or two, not everything. You can see like this one does not cause deep anesthesia. You have to combine. You can see it has good analgesic activity, it has minimal toxicity, but very poor muscle relaxant effect. So you must give it with muscle relaxants. Inhaled non-halogenated hydrocarbons, we're just mentioning them. Cyclopropane produces cardiovascular toxicity. The longer chain of the hydrocarbon, the higher the potency, the colorless, explosive, again, and flammable, may cause radiospasm. So again, you can see it has a lot of negatives, and no wonder we don't use much of it. It should be mixed with oxygen, 15 to 30% cyclopropane for medical use. In contrast to nitrous oxide, its concentration of 20% can produce anesthesia. So the problem is being explosive and flammable, and of course the danger it can bring to the theater labs. So those are some of the examples I've given: non-halogenated hydrocarbons, and of course also the inhaled anesthetics. And we are going to mention, of course, others as we move on. What is the SAL of the volatile general anesthetics? And we are looking at the volatile general anesthetics. We have given them into two classes. We have the hydrocarbons, and you also have the halogenated hydrocarbons. So these are the two classes. We have said some of them are gas. We have the gases and the liquids. The liquids are the halogenated ethers. The gases are like the nitrous oxide, and of course also the cyclopropane. Those are gases. So we have SAL of the volatile general anesthetic. So when we say volatile, again in your mind you classify it into two. The pot, like they have the alkanes and the cycloalkanes and the aromatic hydrocarbons increases in direct proportion to the number of carbon atoms in structure up to a cutoff point. So we are only saying, as we increase the number of carbon atoms, what are you increasing? We're increasing the lipid solubility. As you increase the lipid solubility, these molecules will be able to penetrate. Remember, you're giving them as inhalations. They must pass through the lung tissues, get into the blood. Then from the blood, they must pass through the BBB, get into the brain. So they must have appreciable lipid solubility. But again, you cannot increase that lipid solubility too much, because if you do so, you will lose even the slightest water solubility, and you require again also water solubility for their distribution. Again, if you increase the lipid solubility too much, there will be what we call depotization. They will have such high lipid solubility, when they get into the lung tissues, they'll be deposited in any lipid tissues, and therefore they will not move out. So again, that's why we are saying to a maximum, to a cutoff point. So you increase the number of carbon atoms to a cutoff point beyond which the anesthetic activity will decrease. In the N-alkanes, the cutoff number is 10, while in the cycloalkanes, it's 8. In other words, the cycloalkanes are more active than the N-alkanes. There is a positive correlation between the anesthetic property and solubility in olive oil. The solubility in olive oil, remember, olive oil is organic. So the property, the solubility in olive oil is measured in the lipid water partition coefficient. And the higher the lipid water partition coefficient, we expect the higher their activity to a certain value of the lipid water partition coefficient, because if you go beyond that specific value, then there will be decreased activity, as I've said, because of depotization. The cycloalkanes are more potent and anesthetics than straight chain analogs with the same number of carbon atoms. Remember, cyclic brings about also also what we are saying, the strain and the higher reactivity. Halogenated hydrocarbons, again, we're looking at their SAR, effect of halogenation, and of course, for both the hydrocarbons and also either halogenation. And of course, the halogenation cannot just be done in vain. Of course, anytime you put a halogen, you increase lipid solubility, and therefore improve on these compounds and other positive things. Addition of halogen reduces or eliminates flammability and increases potency. That's very positive. It decreases flammability and also increases potency. High atomic mass halogen increase potency compared to low atomic mass. Remember, these halogens are also increasing the lipid solubility. And of course, the higher the atomic mass, the higher the electron number, the higher the increase in lipid solubility. And for N-alkanes, for N-alkane series, fully saturating the alkane with fluorine abolishes activity except when N equals to 1. If you look at, we're only saying, like, if you have N is equals to 1, that's like methane. Methane, you find like chloroform. Although you have not put fluorine, you have put chloro groups. But you can see chloroform is fully, I believe chloroform, is it chloroform which is here? I think it's tetra. Chloroform, does it have, is chloroform all chlorine? Or is it the tetra? Chloroform, I think it's all chlorine, all chlorine. We will confirm that. But what we are saying is that when N is equals to 1, if you put halogens and replace all the hydrogens with halogens, the resultant compound will still be active. But when N is greater than 1, then you find that the terminal groups, whether the beginning group or the end group, they should have a hydrogen for maximum activity. But for when the carbon is only 1, like in methane, you can replace all the hydrogens with fluorine with retention of activity. But as you increase the nitrogen, and we can understand why, because if you do so, as you increase the nitrogens and you are putting so many halogens, then again you are increasing the lipid solubility to an extent that that drug will undergo depotization. So for N-alkane series, full saturating the alkane with fluorine abolishes activity except when N is equals to 1. When N is 2 carbons, the highest potency was seen when the terminal carbon contains 1 hydrogen. And that's what we are saying, that terminal either on that side or that side, and this N is 2. So you have CF2, CF2, and then the terminal ones, do have a hydrogen to maintain good activity. When the N is greater than 5 carbons, the potency decreases in these series, and we have said why, because of very, very high lipid solubility and deputization. Rate of metabolism through defluorination, you start with the methoxy, you go to enfluorine, you go to sevoflurane, isoflurane, desflurane, and then halothane. So the rate of metabolic defluorination, remove of the fluorine. And you see, when you remove fluorine and you have that free fluoride, the free fluoride are said to also cause toxicity. So the rate of defluorination, in other words, forming free fluorine, which can also, free fluoride ions, which can also bring about toxicity, is that the methoxy has the lowest rate, has the highest rate, which is greater than the enfluorine, greater than the sevoflurane, greater than isoflurane, greater than desflurane, and greater than halothane. In terms of defluorination, then halothane is the one with the least defluorination. Halothane, and as if you look at halothane, this is, I had asked you to draw the structures of these compounds. I hope you did. There are not many, as I have said. And we look at one of the first one, which is halothane, and you can see it is a hydrocarbon, and it's a hydrocarbon that mixes. It doesn't have one, but it mixes all the three halogens, as we had already mentioned. Where enda kwanti? Enda kwanti? That is our chloroform. You can see it has one hydrogen, and all the other hydrogens have been replaced by, at least it still has one hydrogen as a terminal hydrogen, and that is a metabolism. And we will realize that, Auntie, close for me the door, that the toxicity of halothane and the toxicity of most of these drugs is through their oxidation, so, or through their metabolism. So if you have a metabolism of halothane, you can see this hydrogen allows for oxidative hydroxylation there, or for oxidation. So oxidation there. And once there is that oxidation there, the compound, as you can see, it has these square brackets. Square brackets mean it is very unstable, and it very readily loses hydrogen bromide. And to lose hydrogen bromide means it will lose the hydrogen and the bromine, and bromine and that hydrogen, which means now it will have this group here, this group there, whereby the chlorine is pulling away electrons, the oxygen is pulling away electrons. This carbon will be very highly electrophilic, and that is why this compound, acyl chloride, and the carboxylic group, both of them are highly toxic. They are highly electrophilic, because even this carbon here, pull of electrons that way, pull of electrons this way. So this carbon there and that carbon there are highly electrophilic, and that is what brings about the toxicity of halothane. So the toxicity not only of halothane, but toxicity of most of these, whether the halogenated ethers, all the hydrocarbons, halogenated hydrocarbons like halothane, their toxicity mainly is because of oxidation. So halogenated ethers, these are polyfluorinated ethers, have an analgesic and muscle relaxing property that is good, but are more difficult to control. Some are also inflammable. So again, as we have said, you will have you cannot have everything. You will have some positivity and also some negativity. And it is important when you know the negatives, because when you know the negatives, you know how to control, to reduce any hazards. Enfluorine, so we look at the first one, which is enfluorine. And if you look at the structure of enfluorine, we say the structure of enfluorine, I was thinking I have the structure somewhere. Yeah. We had all the structures before. We had the structures before. Yeah, so you can see we have the enfluorine, and as we talked about the enfluorine, it has both fluorine and chlorine, and we did mention that it is it is not an isoster, but it is an isomer, constitutional isomer of isofluorine. So we look at, we say one or two things about it, not much. We're going to say something about halothane, enfluorine, and we can say it's 2-chloro-1,1,2 trifluoroethyl difluoromethyl ether. So if you draw it, you'll be able to come up with that name. It's non-inflammable liquid. That is of advantage. It is mixed with various amounts of oxygen and nitrous oxide. So you give it as a combination for maximum activity. It has a more rapid induction and recovery than halothane, which is an advantage. So it has more rapid induction, and we can understand more rapid induction, also more rapid recovery because of its slightly higher lipid solubility compared to halothane. It has 2 carbon atoms, so it has even more. It has more halogens compared to halothane. It has, and because of that, it has a much more activity compared to halothane. It has a more rapid induction recovery than halothane, which is an advantage. Less frequent arrhythmias, again, that is a big advantage. Has a low frequency of nephrotoxicity due to low fluoride ions. As I told you, we were looking at the way it can generate the fluoride ions. And when it releases, when of those compounds that releases fluoride ions, it can cause a lot of toxicity. So we are saying it has low frequency of nephrotoxicity due to a low fluoride ions. Remember, it has a mixture. It has a mixture of fluorine and chlorine released from metabolism. Very low amounts of very low amounts metabolized to fluoride ions and difluoromethoxy, very low amounts metabolized to fluoride ions and difluoromethoxy through difluoroacetic acid. This is the acid, of course, the difluoromethoxy. Difluoroacetic acid is again the one which will be responsible for toxicity because of the acetic acid. This acetic acid and the fluorine, this carbon they are attached to, has high electrophilicity or high, it's a very strong electrophile, and therefore once you have an electrophile in the body as a metabolite, it can go for your tissues, it can go for the liver tissues, it can go for the kidney tissues and cause a lot of toxicity. But we are going, I believe we'll be able to look at its metabolism very in the next slide. And fluorine drug interactions, it interacts with isonazid, which facilitates its defluorination, renal damage occurs. So we are saying you cannot give it together with isonazid. It facilitates because it will bring about its defluorination, and once it brings about its defluorination, remember we have talked about the fluoride ions causing nephrotoxicity, and that will increase drug toxicity. And at high concentration, it produces convulsions, should not be used in patients with epilepsy. Relaxes the uterus, should not be used as an anesthetic during labor. So that's what I are saying. You need to know some of these conditions or some of these effects or some of these effects of these drugs, so that when you are using them, you will choose your patient, or you will choose your patients wisely, so that you do not cause untold effects which could have been prevented. Then isoflurane, again, if you look at its structure, you'll be able to derive that name. It's non-flammable liquid with faint odor, has a low blood gas distribution coefficient, which leads to rapid recovery from the anesthesia. Has a low blood gas, so it means if the drug does not come from the blood, from the has a low blood gas distribution coefficient, which leads to rapid recovery. That means the drug can leave the blood and go to the gas. Going to the gas is going to the lungs. Remember, in the lungs, that's where we have this a lot of this as a gas. So it means the drug can leave the blood very rapidly and get into the lungs. And when it gets into the lung, it will just be exhaled, and therefore it can lead to very rapid recovery from the anesthesia. It has minimal amounts of the drug, is metabolized again to the fluoride and to the trifluoroacetic acid. Again, that minimizes, just as we have said, of the enflurane that minimizes toxicity. Therefore, kidney, liver, and myocardial functions remain intact, because if you have low fluoride level, you have low trifluoroacetic acid. Remember, the acetic acid or the acetyl chloride, these are the ones that are responsible for the toxicity. The dextro isomer is slightly more potent than the levo isomer. It's a good general anesthetic, and it's a structural isomer of enflurane. We had already mentioned that it indeed is a structural isomer or a constitutional isomer of enflurane. The SAL for the inhaled anesthetics can be summarized as follows. The halogenations of the hydrocarbons and ether increases the anesthetic potency. We have already said that. Halogenations of the hydrocarbons tend to induce arrhythmias in the following order: fluorine, less than chlorine, less than bromine, less than iodine. And no wonder you have not seen iodine in any of them. So this is the order of induction of arrhythmias, and it's increasing as we move that way. So fluorine causes the least, followed by chlorine, followed by bromine. And in fact, with the exception of halothane, the others do not have bromine. They normally have fluorine and chlorine. Due to the presence of asymmetric halogenated carbon in ether, they are better anesthetic. Halogenated methyl ethyl ethers are more stable, more potent, and have better clinical profile than the halogenated diethyl ether. That means one is a methyl group on one side of the ether, and the other one is an ethyl. So those ones were found to have better activity than when you have the diethyl ether. Of course, the methyl ethyl will have more balanced. We have more balanced lipid solubility than the diethyl ethers. These ones have got higher lipid solubility because of the ethyl groups on both sides, and therefore again lack this balance, because we did talk about deportization. That's the only difference. Methyl ether slightly lower lipid solubility. These ones might have very high lipid solubility, resulting in deportization. Fluorination increases ability and decreases the flammability. We have already said that. Complete halogenation of the alkane or ether decreases the anesthetic potency and increases the conversant potency. Again, we did mention you require to have some hydrogen, especially when the middle group, the joining alkyl group is more than 2 carbon atoms. The terminal carbons, you require to have a hydrogen for maximum potency. Presence of double bonds increase chemical reactivity and toxicity. Remember, chemical bonds are sites of higher reactivity than when you have the molecule saturated. So again, you find most of those drugs do not have any unsaturation in order to minimize toxicity, and of course to decrease the reactivity, because as we said, you require a balanced activity. And then now we can look at the synthesis of isoflurane. We have enflurane and we have isoflurane. And again from the name 2,2,2 trifluoroethanol, you can see that's position 1, that is position 2, 1, 2, 3, 2,2,2 trifluoroethanol plus dimethyl sulfate. And you can see that is a methyl group there. Remember, when you have that, it's a methyl. That is a methyl. And this is a sulfate group there. That is a sulfate group, SO4. So we are calling it dimethyl sulfate. And you add potassium hydroxide, and you get 1,1,1 trifluoro. Again, you can be able to know from the name. And then you add chlorine. So you replace the hydrogens with chlorines, and now you have fluorines and chlorines, hydrogen fluoride in antimony chloride. And again, now what we have done is that we have again replaced the chlorines with the fluorines. Again, you add the chlorines. Remember, you require the chlorines at specific positions and the fluorines at particular positions. So somehow these controlled reactions are giving you the halogens at the positions that they are required, giving you the halogens at the positions that are required. And as you can see, as we had said, if you look at the halogenated ethers, they have more carbon atoms. So that's carbon atom, and of course another carbon atom. So they have 3 carbon atoms as compared to halothane, which has only 2 carbon atoms, and that's why we say they have higher increased activity, they have more halogens, they have more carbon atoms, and then of course they have an oxygen which tends to balance also the water solubility. Because remember, if you have these compounds, they have too much lipid solubility, compromised water solubility, again depotization. But as we have said, they will have rapid onset of activity. They will go a bit, they will have not as much depotization as the barbiturates, but they can be used, as we have said, in combination with the barbiturates. Barbiturates, very rapid onset of activity, rapid recovery or removal because of depotization, and then now you maintain the concentration of the halogenated ethers, and that will give you a maintained, of course, in combination again with the other ones we say nitrous oxide and so on. And once you do so, then you have a smooth anesthesia. And of course, when you stop the administration, there will be a flow back. If it is the gas, now it will start moving. You know what? The minute you stop giving even the halogenated ethers. Remember, you're giving them through inhalation. So when you are administering them, there is a very high concentration of those drugs within the lungs. The minute you stop giving, then the concentration in the lungs starts going down. As the concentration in the lungs starts going down, then the higher concentration in the blood starts moving out from the blood again into the lungs, and there is exhalation, and the drug is removed from the body, and of course the person starts to recover. So that is just what we have seen here in the method of synthesis. Again, just explained. It's very simple, just what is being done, adding chlorine, adding fluorine, and so on. I think, I don't know how come, there's one thing, oh, there is one slide I have removed, which I'll bring back for sure, because I have the slide which was showing the metabolism. Sorry about that. I don't know what happened to that slide. So I will bring it back and we'll discuss it next time to show the metabolism of almost all the three, the desflurane, enflurane, and isoflurane, their metabolism, so that we appreciate that all of them can give us the acetic acid or acyl chloride or acetic acid derivative. And that acetic acid derivative is the one, as we have seen it for halothane. It is the one, just as for halothane, that causes the toxicity. So all of them, be it even the enflurane, the isoflurane, and even the desflurane, all of them can be metabolized to give us a similar, and most, in fact, the best is this one, the acid. And once you have the acid, remember these groups are pulling away electrons. They are pulling away electrons. That oxygen is pulling away electrons. This one is pulling away electrons. The whole of this group is pulling away electron. And you have this carbon here, which has high electronegativity. Even that carbon there, high electronegativity. And because of the high, not high electrons, but high electrophile, a very strong electrophile. And this group being a very strong electrophile, it can bind tissues. And in binding tissues, that is how it will trigger nephrotoxicity. That is how it will trigger hepatotoxicity. And that is how these drugs will cause a lot of toxicity. I don't know how I omitted that slide. I'll make sure I bring it back so that we look at their metabolism and understand how these drugs do bring. Even for halothane, it has the same toxicity, and it can cause hypothermia. And I think I left out that slide by mistake. I will bring it back so that we understand the toxicity of these drugs. So the last one, we have the intravenous anesthetics. And the intravenous anesthetics, we have the propofol, we have ketamine, we have the pentasodium, and we have methotrexate. And as I said, if you look at this drug and that drug, really, there is no structural resemblance. But when you go to this, of course, the barbiturates, they will have some structural resemblance. So when we look at the intravenous anesthetics, IV anesthetics are non-explosive. We have seen that some of the halogenated Some of the halogenated ones can be explosive, and more so the hydrocarbons. They can be very, very explosive, and of course give you a lot of problems. They produce rapid loss of consciousness, but insufficient anesthesia. In other words, they cannot maintain. And why they cannot maintain is when you look at this structure and you look at position number 5, you can see the substitutions, very large hydrocarbon substitutions at position number 5, and these large hydrocarbon substitutions at position number 5 ensure that these compounds have very high lipid solubility, and that high lipid solubility makes these drugs to undergo deportization. So they get to the receptor, cause rapid anesthesia, but very rapidly they will move out of the site to the surrounding lipid tissues, deportization, and therefore they will not be able to maintain anesthesia. And no wonder we'll give them in combination, perhaps with halothane or the halogenated ethers for maintenance. So the minute you induce rapid induction, you can withdraw them and now bring in the others, of course, with good maintenance of oxygen. Rarely used alone. Administration of oxygen is recommended, particularly with barbiturates and thiobarbiturates. This is the structure of propofol. You have a hydroxyl group there. Again, you can see this molecule has very high lipid solubility. And as we have seen, it's only this small portion there that is giving it some water solubility for purposes of distribution. Enhances the GABA. And of course, propofol also works like the benzodiazepines, the barbiturates, but again, it will bind its own site. So it enhances the GABAergic neurotransmission in the CNS. It binds allosterically to GABA, just like the benzodiazepines and the barbiturates. But these drugs will bind their own site. So it looks like the GABA receptor has several allosteric sites where these other compounds can bind. Once it binds allosterically to GABA, then remember we said GABA is an inhibitory receptor or an inhibitory neurotransmitter. So when GABA binds a GABA receptor, then it brings about release of chloride ions, and that is inhibitory. And therefore, when this drug binds a GABA receptor at an allosteric site, it will do the same as the barbiturate, release chloride ions, and therefore behave as an inhibitory neurotransmitter. It achieves hypnosis in 1 minute and lasts about 5 minutes. Maintenance of anesthesia is achieved with volatile anesthetics or additional doses of it. So you can keep it on and on, or you can choose to give the volatile anesthetics, and we have discussed them. It is more effective than thiopentosodium, rarely associated with vomiting. Metabolism proceeds rapidly by glucuronidation and sulfate conjugation. So that is propofol. And as we have said, we can see why it has rapid onset of activity and also rapid short duration of action because of the high lipid solubility, whereby it can get into the brain rapidly, but at the same time undergo deportization. Its metabolism, please remember here there is an OH. It has been omitted by mistake, and is propofol. And with an hydroxyl group there, that hydroxyl group can undergo glucuronic conjugation through glucuronide transferase. It can also be, some of it can be eliminated, very small amount eliminated and changed. It can undergo also oxidative hydroxylation at that position here to give us a 4-hydroxy. So 1, 2, 3, 4, 4-hydroxy propofol. It can undergo glucuronic conjugation, as you can see here, glucuronic conjugation at the new point, and also it can undergo, so that is glucuronic conjugation at that point, or glucuronide and 4-hydroxy. Then the difference between this one and this one. So that is OH, 4-hydro. I think they are the same. And the structure is the same. OH there, OH, O glucuronide. Oh, this is the sulfate, sorry. So it can undergo O glucuronic conjugation or the sulfate conjugation. So, so there is first of all oxidative hydroxylation at position number 4, and then glucuronic conjugation or sulfate conjugation. Or it can also go, the hydroxyl group at position 4 can remain without being conjugated, and you have glucuronic conjugation at position number 1. And then also using the enzyme NADP, quinone oxidoreductase, NQO1, which is NADP quinone oxidoreductase, it can undergo oxidation to the quinone. That is oxidation to the quinone. And obviously, even the quinone also can cause a lot of toxicity, because the quinones are also very strong electrophile because of this oxygen pulling away electrons. So that is the metabolism of propofol. We have said it has rapid onset of activity, but again, short duration because of the high lipid solubility. Again, metabolism quite easy, not difficult. There is only the oxidative hydroxylation, glucuronic conjugation, and sulfate conjugation, of course, the oxidation. Then you have the ketamine. Are you strong enough, or are we tired? It's supposed to go up to 11. Primary ring, and this one to be the second ring. So the numbering of this particular one, we can give them prime. So we can say that's 1 prime for purposes of differentiation, 2 prime, 3 prime, 4 prime, 5 prime, 6 prime. And then this other ring, we can give position 1, position 2, position 3. This 1 and 2 are the most important. That is where we have the groups attached. And that is how we have the position 2, and the position 2, as I have said, is this position 2 here. And at that position 2, you have this substituent, which we are calling the 2-chlorophenyl, 2 prime. Chlorophenyl, we have numbered from 1 to position 2. So 2 prime for purposes of differentiation. So the substituent at position 2 of the first ring is the 2-chlorophenyl. And then at position 2 again of our main ring, you have the methyl amino cyclohexanone. So if you look at our main ring is the this one, the cyclohexanone. But the cyclohexanone at position 2, it has the methyl amino. And that methyl amino cyclohexanone has now that substituent. So that's how we are getting that name. We are considering this is our parent ring. This is our parent ring, and of course that is the substituent. The chlorophenyl is our substituent, and our main parent ring is the cyclohexanone ring, which also has a substituent. So that's how that name comes about. And that is, of course, a drug that we call ketamine. If you look at this position there, that position, it has rigidity and has 4 different substituents, and therefore that position is a chiral center. And you can have normally the one that is administered, or the one that is formulated, is both the RS ketamine. So there is no resolution to get either R or S. So you have ketamine hydrochloride, is a very potent, rapidly acting anesthetic agent. The S dextroketamine is more potent than the R levoketamine as an analgesic. But in terms of anesthesia, I think they have equal potency. But normally, because resolution is usually a very expensive process, that is why we call it RS ketamine. So we give it as RS ketamine. The advantage is only in terms of analgesic activity. And of course, as we said, we can still add other drugs that can improve on the analgesic activity. We had already mentioned its mode of action. We had said it blocks NMDA controlled channels, calcium controlled, potassium calcium controlled channels, and we say these are excitatory channels. So when you block them, then you will block transmission. It's suitable for diagnostic purposes and for surgical procedures that do not require muscle relaxation. I wonder which ones are those that will not require muscle relaxation. But again, we can add muscle relaxant. It's indicated for children under 16 years because it is said that above 16 years, it will give wild dreams and hallucinations. So you can only use it in children under 16 years. Above that, it can cause hallucinations. And that, of course, is after. So the recovery you can have almost like nightmares when you are recovering. So that is also not very good. So that is ketamine. Its metabolism. Elimination of action is due to the distribution from the brain into other tissues. We have said all these drugs, because of their high lipid solubility, you can see it has the chloro group, it has this, all this, and of course it has the phenyl group. Because of their high lipid solubility, they will be distributed to the surrounding tissues of deputization. It is metabolized into norketamine. Norketamine acts, which is still an active metabolite in the liver, which accounts for its long duration of action. Norketamine is when you just have oxidative N demethylation of ketamine. Oxidative N demethylation of ketamine gives you norketamine, and you can see again that is a reaction that is catalyzed by mixed function oxidases. Mixed function oxidases. It can also undergo oxidation. So we have said that's position 1, position 2, position 3, position 4, position 5, position 6. So it can undergo oxidation, oxidative hydroxylation at position number 4, 5, and 6. Once it undergoes oxidation in one of the positions, I believe the others will not undergo oxidation, and then that position can undergo glucuronidation. So it can undergo oxidation at that position, and then glucuronidation. Can undergo also oxidation at that position, followed by glucuronidation. It can undergo oxidation at that position, followed by glucuronic conjugation. I mean, by glucuronic conjugation. So that's why we are saying this arrow is showing it can at that position, and that position. So it can undergo oxidative hydroxylation at either of those positions, followed by oxidative or followed by glucuronidation, because of course it's a hydroxyl group. You can see norketamine has just 1/3 of the activity, and it is a major metabolite. So that can happen, but also hydroxylation followed by glucuronidation can also happen. And that's why we have said also conjugated with glucuronic acid, and that has been shown well there. Then the final ones are the ultra short acting barbiturates. I do not know whether you have done, I believe you have done CNS2, although I don't think I'm the one who taught you. I don't know, I can't remember. So if you have done the CNS2 and you have studied in CNS2, we do the anticonvulsant, the anticonvulsants, the antipsychotics, the sedative hypnotics. That is, I think, the other, the CNS2. And I believe you must have covered it by now, hopefully. And if you have studied the barbiturates. Have you covered the barbiturates? I can't remember whether I'm the one who taught you, or if it's not me, it must be Dr. Thu. Have you covered barbiturates? Class. Have you covered barbiturates? Yes, we covered with Dr. Thu, or was it with me? Because I can't remember. You teach so many cohorts in the end. Thank you. In the end, you forget. But I thought I did teach you anticonvulsants. I can remember that. Because under that CNS2, you have the anticonvulsants, you have the antipsychotics, you have the sedative hypnotics in that group. And if you did cover the barbiturates, of course, you are told that at position you have the barbituric acid, and the barbituric acid does not have any CNS activity, because barbituric acid at position number 5, it has 2 hydrogens. For any compound to have any barbiturate derivative, to have any CNS activity, it must be disubstituted at position number 5. must be disubstituted at position number 5. If you look at also the barbiturates at position 1 and 3, they also have nitrogens. Again, for any compound to have any CNS activity, it must have one free nitrogen or unsubstituted nitrogen, which means the position 1 and 3 nitrogens, both of them cannot be alkylated. If both again are alkylated, they will prevent the tautomerism, the tautomerism that is required in the barbiturates or the acid, the acidity. If you have both of them alkylated, then the barbiturates will not behave as acids, and they require to be acids for them to bind the receptor. So I believe those points were brought about, that position number 5 must be totally substituted, and the nature of the substituents at position number 5 will determine whether a barbiturate will be an anticonvulsant like phenobarbital, or it will be a sedative hypnotic. Of course, even the phenobarbital, you can use it as a sedative hypnotic, but it has a very long duration of action, and therefore it will cause you a lot of problems. So you determine whether you are going to use it as a sedative hypnotic, because you want the intermediate. Those ones that are intermediate acting are the ones you use as sedative hypnotic. So you use it as an anticonvulsant. Are you going to use it as a sedative hypnotic, or are you going to use it as an anesthetic? Of course, because you know the toxicity of the barbiturates, that they have an influence on the respiratory system. That is why we do not advocate them as simple sedative hypnotics, because you have the benzodiazepines. And I believe we also studied the benzodiazepines. So when we look at the barbiturates, we're looking at the SAR. The substituents at position 5 are very, very important. When you increase the size of the substituents at position number 5, you increase the ability of these drugs to penetrate the BBB, get into the brain, bring about their activity, and we have said they will bring about the inhibitory activity. They bring about the inhibitory activity, and once they bring about the inhibitory activity, remember it's blocking. They are bringing about the blockade. They are preventing nervous conduction from happening. They block unconsciousness, and then of course depotization because of the high lipid solubility. Depotization, and then of course the person can be able to wake up. So we look at the groups that are at position number 5. If we look at both drugs, thiopental sodium and methotrexate, the groups at position number 5 are huge, and therefore they give these drugs very, very, very good lipid solubility, rapid onset of activity, but also very rapid removal. And as I have said, you will realize that these drugs, the methotrexate, has a methyl group on one of the nitrogens, but one of the nitrogens cannot be substituted for activity. They are used to produce rapid unconsciousness for surgical and basal anesthesia. Induction is very rapid because of their very high lipid solubility. Long side chain substitution at position 5 is essential feature for increasing lipid solubility and hence the rate of passing through the BBB. Not only is that disubstitution important for increasing that lipid solubility, but even for their activity. There is inverse correlation between the total number of carbon atoms substituted at position 5 and the duration of activity. The higher the number of carbon atoms, the more rapid the onset of activity and the more shorter the duration of activity, because the duration of activity is determined by the fact that these barbiturates will move into the surrounding lipid tissues. Their rapid onset is depending on their high lipid solubility that is given by those groups that are found at position number 5. Why they used ultra short acting? You can see ultra short because of the rapid, or because of the high depotization and the short duration of activity. Sulfur atom increases the lipid solubility compared to the oxygen and facilitates its entry into the brain. Short duration of action is due to partitioning from the brain into the body fats. I think I've repeated that enough times. And then it's metabolized by oxidative desulfuration. In other words, it has a sulfur there, and once that sulfur is removed, you get, think, pentobarbital. You get pentobarbital, And once you remove that, then you find that that drug might have very little anesthetic activity, not as much as that which is found in thiopentasodium, because we have said the sulfur further increases the lipid solubility. So if you look at these groups there, you did the SAR of barbiturates. And I believe you also learned that when you bring about branching further increases lipid solubility, and branching nearer the 5 carbon. Branching, when the branching is much nearer the carbon number 5, that even further increases lipid solubility than when it is further on the outside. So if you look at the thiopentasodium, it has all the structural requirements for maximum lipid solubility, for rapid activity. You can see it has 1, 2, 3, 4, 5, 6, 7 carbon atoms. And when you have a barbiturate with 7 to 10 carbon atoms, very, very rapid activity. It should not go beyond 10, because again, when it goes beyond 10, then again, you have too much lipid solubility and the drug will not get to the site of action. So again, as you look at it, you can see both of the nitrogens are not substituted again as compared to methohexyl. Methohexyl, one of them is substituted, and that further substitution of one of them further increases the lipid solubility. So that is our pentasodium. Go back to what you did for its SAR. So go back, check on the SAR of this particular one, not of the barbiturates in whole, of this barbiturate, because you have studied it, and that SAR, you can produce it here for its activity. And of course, I've mentioned some of the very important points on the SAR. Then there's a methohexyl, and as I have said, if you look at it again, not only is it methylated, this is the structure of the methohexyl. You can see it is methylated on one, but it still allows for ketoinotautomerism. You can have, it still allows for ketoinotautomerism. Remember, that is usually a ketone, double bond O, but we are saying, and one of these, you have a hydrogen there, so that hydrogen can move in to give us a double bond, allowing this, there was a double bond here, to move out, so that the ketone which was here exists as an alcohol. Remember, ketoinotautomerism is the ability of a carbonyl substituent to either exist as an alcohol or exist as a ketone. And that can happen, that this here, before you put sodium hydroxide, here is a double bond. You do not have that bond there, and you have a hydrogen there. And that's why we are saying you must, in all barbiturates, you must have one of the nitrogens and substituted, having a hydrogen substituent to allow for that ketoinotautomerism. If you substitute that and substitute that barbiturate will not have activity, because the barbiturates, as I have said, require to be acidic for them to bring about pharmacological activity. So when we look at methohexyl, we are saying there is that methyl group which further increases the lipid solubility. When we look at methohexyl, again, there is branching near the position number 5, increasing activity. We do have the long chain again, 1, 2, 3, 4, 5, 6, 7, 8, 9. But you can see in methohexyl, we also have the challenge of unsaturation. And you do know, and saturation brings in sites of high rate of metabolism, and therefore that is why because of the higher rate of metabolism of methohexyl, there is compensation in the increased number of the carbon atoms, so that it also can still give us good activity. Not only is there compensation in number of carbon atoms compared to the pentasodium, whereby I think we have seen there is one more, there is also the methyl group, which is on the nitrogen, which further increases the lipid solubility. So we are saying the introduction of the unsaturation in methohexyl makes it more susceptible to metabolism. When you make it more susceptible to metabolism, it means it will reduce its duration of activity. But to compensate for that, you give it much lipid solubility, because drugs with higher lipid solubility also are metabolized less slowly. So that compensation, so that it still can bring us good anesthetic activity. So when we look at those structures, we can be able to understand their structural or their structure in terms of the activity that they have. So we are seeing the N-methylated barbiturate, that is, it is a N-methylated barbiturate that is more basic. It will be more basic because that methyl group pushes in electrons, making that nitrogen a stronger base. So it's more basic than the non-methylated barbiturates. So of course, when you put a methyl group, as I've said, it's attached to a nitrogen. What does a methyl group do? It donates electrons into the system. The nitrogen, which is next to the methyl group, is more basic because it has a higher concentration of electrons. It can bind, or it can attract, it can bind, it can accept protons more readily, and therefore it is more basic. The higher pKa or weaker acidity increases the concentration of the lipid soluble free acid form at physiological pH. Remember, these are acidic in nature. If this drug has very high acidity, it will be more ionized. Now that we have put the methyl group decreases its acidity. It is still acidic in nature, but it's a weak acid, a much, much weak acid. And the weaker the acid, the more the ionization. The lesser the ionization. The lesser the ionization, the higher the concentration of the form of this barbiturate that will penetrate the lipid membranes to give us a very high concentration that we need in the CNS. So please do be able to understand, when you have the higher pKa, low Ka, and we are only saying the higher the pKa, the higher the basicity of that molecule. But remember, it is still acidic, but a very weak acid. And because it's a very weak acid, less ionized, the more anionized the more an ionized form has higher concentration, and therefore it penetrates the membranes, gives you what you require in the brain for activity. N-methylation decreases the duration of action due to high rate of deputization. Of course, when you get the group, the compound, this compound has higher lipid solubility because of the N-methyl group compared to the non-methylated, then that means higher lipid solubility, higher deputization, shorter duration of activity. So I hope you can be able to explain the rapid onset, the short duration in terms of lipid solubility. It has extensive hydrophobic character because of the long unsaturated side chain. We have seen it has up to 9 carbon atoms. So it has high hydrophobic character because it has, of course, 9 carbon atoms. It has also the N-methyl group, all that increasing its lipid solubility and increasing its ability to penetrate both the lipid barriers within the periphery and the BBB to get into the brain, but also increasing the deputization. It can rapidly penetrate the CNS after IV injection and then redistributed rapidly to other body sites and undergoes rapid metabolic inactivation. Why rapid metabolic inactivation? Because of the unsaturation. It has an accessible site of metabolic inactivation, the methylene alpha to the triple bond. So because of its high, because of this, because of that high, because of that triple bond, the methylene alpha, this is the methylene alpha to that triple bond, that methylene has a high degree of inactivation, or of course hydroxylation. It will undergo hydroxylation. This is a CH. Remember, that's a CH2. It can undergo hydroxylation because therefore the unsaturation is also triggering high rate of metabolism. Again, short duration of activity. When you want the patient to recover, you do not, of course, as we have said, you don't want drugs that stay in the body for too long. That person will take forever to time to wake up. So, of course, there is an advantage of a drug that has a short duration of activity, as long as we have said you have other drugs that you can give so that there is maintenance of. There is maintenance. Remember, this one you're giving it IV. So if it is staying too long if it has a long duration of activity, by the time you clear what is in the blood, that person will have slept for a very long time. But the others which we are giving as as inhalations. We say the minute you stop giving that drug, the concentration in the lungs goes down. Whatever is in the blood now takes the other direction, starts moving out, and therefore the concentration of that drug in the body will go down very quickly. But remember, these ones we are giving them as IV. They are already in the blood. So now, for you to make sure that the person doesn't sleep for a very long time, these drugs have high lipid solubility, deputization, being removed from the site of action, and therefore they will have the person will have rapid onset and very rapid recovery. And I think that is the last slide for general anesthetics. As I have said, you have done barbiturates. We are only looking at those two barbiturates because the others will not be used, like the phenobarbitons and so on, cannot be used as general anesthetics. And you can understand why. They have very low lipid solubility. They have slow action, long duration action, very long duration of action. They have low lipid solubility, and therefore they cannot be used as general anesthetic. So refer back to your SAR of the barbiturates and just pick those two barbiturates if there is anything I've left out, so that you can have, you can understand why the barbiturates are indeed ideal for use as general anesthetics. And I think with that, thanks God, we have finished the general anesthetics. Apart from that, I said 1 or 2 slides. Unfortunately, I don't know how come. I don't know where it happened to them. I'll look for them. 1 or 2 slides whereby we will look at the metabolism of the halogenated ethers. And of course, halogenated ethers, so that we can understand why they have high toxicity, and also halothane. We have already looked at the metabolism of halothane, and I hope we have understood why it has high toxicity. Did you remember the structure of chloroform? You know, after some time, these things you remember slowly. So of course, chloroform has 3 chlorines and 1 hydrogen, isn't it? So chloroform should be 3 chlorines, 1 hydrogen. So again, as we said, if you put too many of the halogens again, the drug, of course, also can become even more toxic, because the more electrons we are withdrawing, that electrophile carbon can cause a lot of toxicity. So I think with that, not unless if there are any questions, I am happy we are done with the general anesthetics. Any question? Any question? Are we okay, class? Tuko sawa? I love it when you tell me we are okay. Hoping you are also genuine, because sometimes students say we are okay, and when it comes to the exam, they start saying, no, you are never okay. And yet they never asked any questions. But I'm hoping that you are okay. Any questions? So then now, having finished that, the next is another very small topic where we will be doing central muscle relaxants. Central muscle relaxants, again, a very short topic, and we will end with the hallucinogens. So this topic we finished very early. So you need to tell me when you want your cut. I think we need to be serious on the cut. Actually, now we are almost there. Thank God, this is one of the topics that is not very big compared to the others we have studied. Any questions? Then sign in if you do not have any question.